Hello guys, welcome back to Clinically Clear. So today let's cover the growth and development part of preventive pediatrics. So basically, what is growth? The increase in physical size. Development is the increase in function and skill. So they are not the same. That's all. This comes in pediatrics. It's not that important in community medicine. So let's skip to the next part. Factors affecting growth and development. This also, just to add volume to your answer, you can include it like genetics can influence height, nutrition. Better the nutrition, better the growth and development. Sex. The pubertal age group differs between in males the puberty occurs a bit later compared to females, so the growth and development will also differ between males and females. Generally, end height is more in males compared to females, so sex plays an important role. Age. Maximum growth is during fetal life, the first year of life, that is infancy, and puberty. That's where most majority of the growth takes place. Psychological factors like love, care, emotional support from parents, all that enhances growth, does not hinder it. Physical factors like lighting, ventilation in the child in the house that the child is staying, that also makes a difference. Infections plays a huge role. Chronic diarrhea, infections like measles, all these can lead to, all this can hinder the growth and development of a child. Social economic status, poorer the patients, lack of sanitation, lack of good quality nutrition, all that will lead to decreased growth and development. So just use a bit of common sense, just some factors: genetics, nutrition, age, sex, socioeconomic status, psychological factors, physical factors, infections, anything that can improve growth, anything that can hinder growth, all that you can add. Then, now coming to the important part, growth assessment. What all you'll check? You'll check for weight. Average birth weight in our country 2.8 kgs. Less than 2.5 kgs, low birth weight. Less than 1.5 kg, very low birth weight. Less than 1 kg, extremely low birth weight. And birth weight doubles in 6 months, triples in 1 year, quadruples in 2 years. So, doubles in 6 months, triples in 1 year, quadruples in 2 years. Now, if the baby is not able to stand, how will you measure the weight of the baby? Using something known as Salter scale. Basically, it is like an underwear which can be tied to a weighing machine, weighing scale. So basically, you'll make the baby sit on that. Drawing is a little bad. You'll make the baby sit on that Salter scale, the underwear of that Salter scale, so underwear kind of thing, and you'll tie it to the weighing scale. So that time you will get the weight of the baby, that is Salter scale. It has a precision of up to 100 grams, not 100 milligrams, 100 grams. So that is weight. Then coming to height. Height or length will measure using infantometer. Length you will measure using infantometer. Height you will measure using stadiometer. Supine position length, standing position height. So 50 centimeter at birth. Height is about 50 centimeter. Length is about 50 centimeter at birth. First year it increases by 25 centimeter. Second year it increases by 12 centimeter. Third year it increases by 9 centimeter. Fourth year it increases by 7 centimeter. Fifth year it increases by 6 centimeter. This you just have to memorize. So 50 at birth, then increases by 25, increases by 12, increases by 9, increases by 7, and then increases by 6. Final height, 98% of height growth, it is completed by the age of 18 in male and 16 in female. Meaning skeletal growth is completed at the age of around 22 in males and at around 20 in females, but 98% is done at age 18 in males and 16 in females. This is regarding height. Then you'll also check for head circumference. From the supraorbital margin to the occiput, you'll take a non-stretchable tape. It is about 34 centimeter at birth. Chest circumference you will do at the level of fourth intercostal space. At birth, head circumference is more than chest circumference. At 1 year, it becomes approximately equal, and after 1 year, it's throughout life always chest circumference will obviously be more than head circumference. This is just the additional point. So now most all these are age dependent parameters. Okay, they are affected by age. They'll increase with age or they'll decrease with age. It's different, like head circumference. So they are age dependent, but you have some age independent factors as well, parameters like weight for height. Weight for height is age independent. Skin fold thickness, age independent. Mid upper arm circumference, very very important. It is age independent. You will take mid upper arm circumference from the midpoint of the acromion to the olecranon process of the ulna. Midpoint, you will take the mid upper arm circumference. You will take this only after 6 months, and you won't measure mid upper arm circumference after the child is 15 years old, 16 years old. So only up to 5 years. After 6 months, you will measure. Up to 5 years, you can take mid upper arm circumference. Midpoint of olecranon and acromion process. What will you use? You will use something known as Shakir's tape. In this tape, when you take the mid upper arm circumference, if it is more than 12.5 centimeter, it is normal. If it is between 11.5 and 12.5, it comes under moderate acute malnutrition. If it is less than 11.5 centimeter, it comes under severe acute malnutrition, SAM. Why acute malnutrition? Is because triceps here, the muscle bulk is not just the biceps but the triceps. This triceps is like the first muscle to decrease weight to gain weight. Whenever in our body, when it comes to nutrition, the triceps muscle is the first one to either lose weight or gain weight. So it is very very accurate. Mid upper arm circumference is a very good indicator of acute nutritional status. So less than 11.5 SAM, 11.5 to 12.5 moderate acute malnutrition, and more than that is normal. Shakir's tape is what is used. Now, child comes to you with OPD. You want to do growth assessment. First thing you'll do is check weight for age. Weight for age, WFA, most important. It is the general indicator of malnutrition. Acute malnutrition also, weight will decrease. So weight for age will be low. Chronic malnutrition also, weight will decrease. So weight for age will be low. So it is decreases in both chronic and acute malnutrition. It is the general indicator of undernutrition or malnutrition. That is weight for age. What is the classification for this weight for age? It is Gomez classification. Very very important. Gomez classification is used for weight for age. So what will you do? Basically, if the weight for age is normal, good, but not always. Let's say the weight for age is normal, but then child has lot of edema. It could be kwashiorkor. Now, kwashiorkor is what? Kwashiorkor is predominantly protein deficiency. When there is protein deficiency, there will be edema. So even though there is wasting, malnutrition, loss of muscle, so there will be weight loss. But because of edema, fluid retention, there will be weight gain as well. So it will cancel each other. So weight for age will appear normal. So in kwashiorkor, weight for age can be normal, but then there will be a lot of edema. So when this happens, you have to use something known as Wellcome Trust classification. So normal weight for age, usually it is good, no malnutrition. But normal weight for age with edema, it can be kwashiorkor. Then you have to do Wellcome Trust classification. Okay. Now weight for age is low, low weight for age, malnutrition. How will you, with what is the criteria according to Gomez? When the weight for age is less than 80% of expected weight for age, it is low. Now this low weight for age can be then after, okay fine, now you know it is malnutrition. Okay, low weight for age is malnutrition. Now you want to know whether it is acute or chronic. See, think about it. When there is chronic malnutrition, do you think the child will grow in height? No, height child will not grow. Acute malnutrition, the chronic malnutrition best example is malabsorption syndromes. Acute malnutrition, child suddenly is not having any food for 3 days, some starvation or something, or child is having an acute diarrheal disorder. Acute malnutrition. Do you think height of the child will suddenly decrease? No. Weight will obviously decrease when there is acute malnutrition. But do you think height of the child will decrease? No. So this is the principle. Weight for the height, it will decrease in acute malnutrition. Why? Because height is not changing in acute malnutrition, but weight will obviously decrease. So weight for height is the best indicator for acute malnutrition. Whereas height for age, height will decrease in chronic malnutrition. Chronic malnutrition, child will not grow in height. So height for age will be less. So height for age is the best indicator for chronic malnutrition. Weight for height in chronic malnutrition, it will appear normal. Why is that? Because weight is reducing because of acute malnutrition. Okay. And in chronic malnutrition, we know that height is reducing. So in chronic malnutrition, in chronic malnutrition, weight will reduce. Correct. Weight will reduce in any malnutrition. Height will also reduce in chronic malnutrition. So weight for height will appear normal. That is important. Height for age in acute malnutrition, it will be normal. Acute malnutrition is height changing. No. Suddenly for 5 days child is getting diarrhea. Height will decrease. No. So normal and acute malnutrition. So that is important. Weight for height, indicator of acute malnutrition. Height for age, indicator of chronic malnutrition. Now, in both of them, when do we say the parameter is low? When it is less than -2 standard deviation. So, this comes under Waterlow's classification. So, weight for height and height for age, we use Waterlow's classification. Low weight for height, less than -2 standard deviation, is known as wasting. Low height for age, less than -2 standard deviation, is known as stunting. If both acute malnutrition, chronic malnutrition, stunting, wasting, both are present, combined malnutrition. Understood? Simple. So Waterlow's classification, less than -2 standard deviation for weight for height and height for age. Gomez classification, less than 80% of expected weight for weight for age. And Wellcome Trust classification is normal weight for age but with edema. Development through developmental milestones, pediatric topic, not important. Then next coming to growth charts. Now growth charts was invented by someone known as David Morley, but later modified by WHO. There are more than 49 types of growth charts. We use them for what? Growth monitoring. Most commonly used weight for age growth chart is weight for age. We use weight for age because weight for age is a general marker for malnutrition. If I take height for age chart, acute malnutrition I won't even be able to detect. So we use weight for age growth chart. In India, there is something known as MCP card, Mother and Child Protection Card, okay, which we give to the mother and to basically keep a track of the child's health. Here, you will have separate weight for age growth charts, a pink chart for girl and a blue chart for boys in this Mother and Child Protection Card. What else will you have in this card? You will have the name, you will have the age, you will have the registration number. So it can be used for identification and registration. You will have the date of birth of the child. You will have its birth weight, whether it was a low birth weight baby, premature baby, etc. It is also acts as an immunization card. Immunization status will be there. It will have a checklist of developmental milestones. If a baby has achieved a milestone, you can tick it. You'll have the sibling health information, whether the child has any sibling health, whether the child has any sibling, and if there's any relevant health information for that. Then if the mother has used any child spacing methods like contraceptives, oral contraceptives or UCDs, all that you can mention in this. There's a space to mention in this card. So these are all the facilities in the MCP card. What's most important is you have in the mother and child protection card, you have the growth chart. You have a pink chart for girls and a blue chart for boys. Weight for age charts. We use weight for age charts. Then you also have identification, registration, date of birth, birth weight, immunization status, developmental milestones, child spacing methods, sibling health information, etc. Other relevant information. Basically, a card with which you take to the OPD every time you go for health checkup or to get a vaccine. Okay, so this is about introduction to growth chart. Types of growth chart, mainly two types are there. You have ICDS growth chart. ICDS growth chart is what is used in Anganwadi center. Very, very important. In India, we use ICDS growth chart. ICDS, Integrated Child Development Service. Okay. You also have another one known as Field Growth Chart or Road to Health Growth Chart or WHO Home-Based Growth Chart or Boston Health Chart. All of them are same. Okay. Now, standard for ICDS growth chart. Basically, to make that chart, you need some data. So that is based on multi-centric WHO growth reference studies, which was conducted in 2003 to 2006. That is for ICDS. Whereas these Boston Road to Health growth chart, they are based on Harvard standards. So Harvard standards. So therefore, they are American in nature. Whereas WHO multi-centric growth reference studies, multiple different countries were used to collect data. Both of them are weight for age charts. Okay. Now, what is important is in ICDS growth chart, you have 3 reference curves and 4 zones. That is, it is a weight for age chart. Upper reference curve, URC, is 0 standard deviation. Middle reference curve is -1 standard deviation. Lower reference curve is -2 standard deviation. So now you have 4 zones. Above this, you can have overnutrition. Above this, actually, till +2 standard deviation, it is normal. But then you'll have overnutrition. Then you have a green zone. Green zone is normal. Green zone is normal. Up to minus, okay, this here I've made a mistake. So this should be minus 2 standard deviation and minus 3 standard deviation. I apologize for my mistake. So basically, upper reference curve 0 standard deviation, middle reference curve minus 2 standard deviation, and lower reference curve is minus 3 standard deviation. So 0 to minus 2 standard deviation is normal. Minus 2 standard deviation to minus 3 standard deviation is moderate undernutrition. Less than minus 3 standard deviation is severe undernutrition. So you have green zone, yellow zone, red zone. This is about the 3 reference curve and 4 zones of ICDS growth chart. Whereas in and ICDS growth chart, you have separate for boys and girls. You have a blue chart for boys, you have a pink chart for girls. Whereas for road to health charts, WHO home-based growth charts, you have same for both sexes. One chart which is used for boys and girls. I'll tell you why. And here you have 2 reference curves and 3 zones. Okay. So the upper reference curve is the 50th percentile curve in boys. The lower reference curve is the 3rd percentile curve in girls. So you have both a boy curve 50th percentile and a lower reference curve 3rd percentile for girls. So it is an integrated for both sexes, boys and girls. And above the upper reference curve, overnutrition. Between the upper reference curve and the lower reference curve, you have the road to health zone, the green zone or the zone of normality, road to health. This is the normal zone, WHO road to health zone. Less than the lower reference curve, it is severe undernutrition. So this is about the main differences between ICDS and WHO road to health charts or field growth charts. ICDS blue for boys, pink for girls, WHO home based, same for both sexes. You also have certain other growth charts like WHO service growth charts, Government of India authorized growth charts or Government of India recommended growth charts. But these are the ones that are important, the above mentioned ones. Now coming to why do we need growth charts? Best tool for growth monitoring. And in growth monitoring, what's important is it is not where the child is currently. It is not important if the child is currently in yellow zone, currently in green zone. It is important whether how the child is progressing. The trend of the curve is important. Flattening curve indicates that there is growth failure or decreasing curve, malnutrition. So if the child who was in yellow zone, if a child who was in red zone has now come to yellow zone, that is a good trend. Just because the child is in yellow zone does not mean, oh, it is a huge problem. But even if a child is in green zone, like the upper part of green zone flattens and comes to the lower part of green zone, it is flattening of the curve. Something is not happening, child is not growing. So it is the trend of the curve that is more important than the zone of growth. Okay. So there's a good tool for growth monitoring. A good tool for diagnosis. We can identify the high risk children based on the zone. Child is in lower part of yellow zone, high risk of child going into severe undernutrition. So it is a tool for diagnosis. So it is a tool for action. The Anganwadi worker can see, okay, this child has come to the red zone, malnourished, this child is in the yellow zone, malnourished. I can now give the child supplementary nutrition. So Anganwadi workers can take action based on the data in the growth chart. So it is a tool for action as well. It is a tool for education. The mothers can be educated about the importance of nutrition. Basically, you will tell the mother, look, your child is in yellow zone, not getting enough nutrition. You have to feed the child much better. So it is a tool for education, especially to educate the mothers. It tells us the impact and efficiency of programs, whether these programs such as ICDS, all of them are working, whether growth and development of children in our country is good. So it tells us the impact, efficiency. It gives us data for policy making and planning as well. So these are the uses of growth chart. Tool for diagnosis, tool for action, tool for education, tool for growth monitoring where trend is more important than the zone, and impact and efficiency of program, policy and policy making and planning. This is about growth and development. Thank you for watching.